Today we're talking about optimising sedation for our critical care patients. And when I talk about optimising sedation, mostly I'm referring to reducing the amount of sedation that we give our patients, but sometimes the right amount of sedation for an individual patient might be to increase the sedation because the patient's particularly agitated or distressed. So I am using the term optimising to mostly refer to reducing sedation. So when we look at the evidence for why sedation matters, what we find is that although there's not absolutely universal evidence, most of the evidence suggests that lighter sedation is more beneficial for our patients, that patients might have a shorter length of hospital stay or ICU stay, might have shorter duration of mechanical ventilation. The area that we really don't know very much about is how well patients do once they get home. Is their psychological health better or affected by the amount of sedation they get or not? So by referring to psychological health, I'm meaning memories or anxiety or depression after going home. So that's what we're trying to improve, and the things that we might use to improve it are things like analgesia first sedation, where it does look like by focusing on pain and analgesia before sedation, you can reduce the duration of mechanical ventilation and ICU length of stay. Other interventions like complex interventions involving a bundle of care like the ABCDEF bundle, or nurse-directed sedation protocols, or daily sedation of interruption. Some of those things we have mixed results. In some settings they seem to work, and in other settings they don't prove beneficial, and they might even result in more sedation being needed by some individual patients. So what does this mean to us? What it says is that we need to be thinking about our usual care, our context of care, because the right interventions are not going to apply across all different practice settings. We certainly should be helping our patients achieve comfort first. We should be driving a multidisciplinary conversation about what we're trying to achieve in relation to sedation for each individual patient. And then think about what strategies might be beneficial for each individual patient that you care for to get them more awake and breathing for themselves and then mobilising so that they can get out of ICU as soon as possible. The other thing that you might think about doing is, if you don't currently conduct audits of sedation practice within your ICU, have a think about whether you should be auditing practice in your local setting and see what you do well and what you don't do so well. And that will help you identify areas for practice improvement in your own practice setting. Don't forget that education is an important component of changing practice. By itself, it's not usually enough to change practice, but it's essential to build as a baseline when you then start to try and implement other strategies. So there's no one answer that suits every patient or every practice setting in regard to optimisation of sedation, but there's lots of different strategies that you can consider.